Okay, Assalamualaikum and good afternoon, everyone. Welcome to the second Malaysian Oncologist Tumour Board, and thank you for joining us today. So this month's Tumour Board will be on early breast cancer. So for this time, we have four speakers. We have Dr. Kiley, who's going to have a fire chat on genomics and early breast cancer. And then we have Dr. Natasha, Dr. Fadhlina, and Dr. Ranga Sami. From practice. She's from KPJ Hospital. Then an oncologist there. And then we have Dr. Ranga Sami, who's a clinical oncologist from Hospital Sultan Ismail. Each of them will present a case that would be very interesting. So please stay tuned. So shall I invite Dr. Kiley to have his fire chat, and maybe Kiley can take on from here. Thanks, Kiley.
Yes. Thanks, Mastura. So I will share my screen. Okay. I presume that everyone can see my screen, yeah? Okay. So we'll start off this second tumor board, okay, with a fireside chat on the use of genomics in hormone receptor positive and HER2 negative early breast cancer. Now, the basis of this is, we have to go back to the basics is, in early breast cancer, in my opinion, the two main goals of care is firstly to maximize survival in our patients, but we must also not forget to maximize survivorship for our patients. So when we talk about survivorship, I'm talking about mainly about long-term side effects and how people can get back to their normal lives as well. And we mustn't forget the impact of the treatments that we give them, especially chemotherapy. So there are some challenges in treating patients with hormone-positive, HER2-negative early breast cancer. So for all early-stage breast cancers, the issue is the endpoints in terms of long-term survival are usually not palpable like metastatic breast cancer, where you can actually do a scan and you can see whether the tumor is shrinking or not. So for early stage breast cancer, we can't really tell, in the patients that come and see us. And only if they relapse, then we can kind of tell that the outcome that we wanted was not met. And the next thing is there is a significant proportion of patients within this gray zone, where there is uncertainty if treatment should be escalated, by giving chemotherapy, targeted therapy, or should therapy be de-escalated, where patients who would not benefit from extra treatment and we save them from the unnecessary side effects. So it's really the balance in between over-treatment and the unnecessary side effects versus under-treatment, where we can actually lose out on a preventable relapse. Now, the general trend for us all, I can confidently say is we would rather over-treat. Rather, we would sacrifice unnecessary side effects, okay, as this would be commonly seen as a lesser evil, to a higher risk of relapse. But as I said earlier, we cannot downplay the long-term side effects on our patients because they can truly affect their quality of life in the long term. So in this theme for early breast cancer, moving towards precision is very much needed now. Okay, let's kickstart this first session with a short case. Okay, so this is a 45-year-old lady who is premenopausal with no family history of cancer. So she had breast conserving surgery, and she was found to have a 22mm invasive ductal carcinoma, a grade 3. None of the 3 nodes were involved, and the margins were clear. Okay, so her ER is 3 plus 90%, and the PR is 2 to 3 plus 70%, and the HER2 is negative, and the Ki67 is 18%. So she has agreed to have radiotherapy. So the first discussion point is whether this patient, should she have chemotherapy, or should she be someone that we can consider for genomics to guide whether chemotherapy is needed or not. So perhaps I can get some views from our fellow panelists. So what you all think? Ranga, you have any thoughts or
Yeah, thanks,
case?
Dr. Kiley.
Uh,
Okay, in my practice, genomic study is not routinely with we subject the patients to because of the financial issue. So if this patient comes to my clinic and she's 45 years old and she's a premenopausal and she got a grade 3 disease, I more tend to give chemotherapy for her because I mean, most of the times, this patient is supposed to go for the genomic study by right. But in my practice, normally, if the patient has no financial, in terms of financial toxicity, and so we tend to give chemotherapy in a premenopausal woman. Yeah.
understand your concerns. Yeah.
Mm.
Nina, you have any thoughts on this?
Hi everyone. So like Ranga, I practice in a public center under the Ministry of Education in UM. So in our patient population, again, we don't get many, if at all, that can afford genomics. So we're talking about sort of Oncotype DX in a premenopausal lady. It can fetch up to 20 to 25,000 ringgit for the test. And then sort of the other unknown factor is what if the test comes back to a risk score or recurrence score that you're not sure what to do in the gray area still. So there's a lot of unknowns there. So majority of my practice, I don't really see patients with Oncotype DX or MammaPrint result. That being said, this patient is 45, so young, premenopausal. It's really debatable because on one hand, the Ki67 is inching to 20%. You know, where is your cutoff? Is there really a cutoff? Is 16% and above is cutoff? I know why it's 18%. It's that area. It's like sort of inching towards, is it a luminal B disease? Because it's a grade 3 and it's a T2.
Yeah.
So it's a really tricky one. And you wonder whether ovarian hormone suppression and endocrine therapy alone would be sufficient.
Yeah, true. So that's a great point. So the issue with cost is real. Okay. The cost of genomics are quite expensive. Oncotype DX indeed is in between, I think, 23 to 25,000 ringgit. Yeah. So if you want to go ahead with chemo, what would you want to give her? I mean, if let's say you will have to decided that you want to give her chemo.
Kiley,
can I?
Yes,
Yeah, sorry. Can I
Mastura.
ask Kylie first? The case is below 50 years old patient, right?
Yes,
And
yes.
you know that the size of the tumor is
22 millimeter. Yeah.
Sorry, Mas, you're breaking up.
You're breaking up, Mas.
Great. Sorry. So in the RX Wonder study, they stratify the risk, right, to those who are grade 3 and 1 cm, then those who are like 2 cm grade 2, and then those who are 3 cm grade 1, right?
Yes. So I will come to that soon in the next few slides. Yeah, so we'll definitely expand on that, how we can better risk stratify these patients. But we come back to the chemotherapy question. What do you think? As in, what would you want to give her?
Kylie, for me, I will go for TC regime for 4 cycles, 3 months of treatment rather than 6 months of treatment. So docetaxel and cyclophosphamide is my choice of chemotherapy for this patient.
Natasha, What
Hi,
do you think? Hey, Natasha.
okay. I would also agree with taxing must be in place. And the tumor is actually is borderline. I would feel that I would agree with Sangha, probably minimum of 4 cycles of chemo. Have we discussed about BRCA for this patient? I'm sorry.
Not yet. Not yet.
Not yet. All right.
But we'll just assume that she doesn't. I mean that she's BRCA negative. Okay. Yeah. And Nina, yeah, you have any?
I mean, I think I was on the side of doing less just now when we talked about ovarian hormone suppression and endocrine therapy. But if I'm being pushed towards chemotherapy, I would really then think of the standard approach of anthracycline and taxane. I would go ECT 6 cycles.
Okay, can. So we'll move on to the next slide. Okay, so this is just a summary slide on the available genomic tests that we have in Malaysia, what they're about, what the evidence for each of them show, what's the target population we can use them for, and also the estimate cost for these patients. So we can see here the first two, which is Oncotype DX and Memoprint. So they are the only prospectively validated studies, tests, both of them in very large studies. So for Oncotype DX, you can use them for N0 to N1 disease, and the same thing for Memoprint as well. The caveat is for premenopausal patients, the only useful test would be Oncotype DX. And as Mastura alluded to, we can further risk stratify them using clinical risk factors as well, which I'll come to in the next slide. Yeah, the rest, like Endopredict and Prosigna, they're mainly used in the postmenopausal setting, and the evidence is mainly retrospective in nature. So here, if we apply the clinical risk criteria from the TAILOR-X study here for N0 patients, so she would be classified as a clinical high risk. Okay, and let's say we did Oncotype and RS came back as 19. Okay, I'm not sure. Have you all had much experience using this test in premenopausal patients? But if you have, please feel free to weigh in on your thoughts on this.
Okay. If I can just add here, okay. So the patient fulfills the criteria for Oncotype DX, all right. And the thing is, I think that the premenopausal proportion inside Oncotype DX was not a lot. Like, is that the number of patients who were premenopausal in the studies were under. So I am very hesitant, or I'm a bit cautious when I want to apply Oncotype DX patient high risk clinical features. For example, this 7 that is close to 20%. So, but this out. So if let's say the patient gets an Oncotype score high, then yeah, of course. And then if let's say it's not high, but it's close to high, then yeah, so then that's the issue there. So but of course I will discuss with my patient. It is an option. This kind of patients were included in that study. So I will discuss this with my patient, but I would err towards over treating here.
Yes.
In premenopausal patients.
Okay. All right. So perhaps in the interest of time, because I know that we've got 2 other thoughts, so more, we'll move on. So if we look at the guidelines on the use of Oncotype DX in premenopausal women, so the cutoffs are different for the clinical high and clinical low risk patients. So for this patient, she's a clinical high risk patient. Okay, so any cutoff, okay, so if the RS is actually less than 16, then of course there is no chemotherapy benefit. But the issue is the RS is 19. So here you can see the chemotherapy benefits start to emerge. So here at 6.4%. Now the thing is this 6.4% chemotherapy benefit or 8.7%, is that due to the cytotoxic effect of chemotherapy, or is that due to the ovarian suppressing effect of chemotherapy? So when we look at TAILORx, right, when they look at the subgroups, it's actually quite convincing. So these are this is a forest plot, okay, looking at patients by age and menopausal status. You can see here for the hazard ratio of IDFS as well as this distant recurrence here, the patients who were basically reaching 50 years old or the older 40-year-old patients, they tend to benefit more from chemotherapy versus the very young patients who are less than 40 years old, and also those who are already menopausal at the time of randomization. Now you can see that the chemotherapy effect actually increases as the age actually goes up. Now this is possibly because of the chemotherapy effect on menopause, because these patients are more likely to be menopausal after chemotherapy compared to those who are at a younger age. So the discussion here is whether is it chemo or is it ovarian suppression. So, but the jury is still out. Okay, so I think it is not wrong to give chemotherapy. It's also not wrong to consider ovarian suppression for this patient.
Okay, so
Okay,
what I can summarize here, Kylie, is that those patients who are in the medium range age, right? They're like the 40-ish, like this patient that you are discussing.
Yeah.
Giving the chemo in these patients made them achieve early menopausal state, and that could have contributed to them having a better outcome.
Yes, and we also know that ovarian suppression, also
gives-
improves survival, right? Okay, so that may be the case, although there is no randomized clinical trial to answer this question. But experts around the world, they don't agree on this. So both ways are also fine.
Okay, I just want to ask, if we start patient on chemotherapy and the patient, do you start them on ovarian suppression as well upfront during chemotherapy, before you start the chemotherapy or during chemotherapy? Or do you consider that once you have given the patient chemo and they do not have menses, I know not having menses is not equal as menopause, but do you wait until they get menses before you start them on ovarian ablation?
Okay. So personally, if the patient is already in the high 40s, as in the late 40s, the likelihood of premature menopause from chemo is very high. Okay, so they will lose their periods, and it depends on the risk. If let's say they are very, very high risk, they have stage 3 cancer, I will assume that they haven't reached menopause and I will just ovarian suppress them anyway. But if let's say in this patient, a stage 2 patient, I would give them chemo, and if they lose their menses, then I would give them, I would check the hormone levels after chemo. If they are still detectable, then I would ovarian suppress them. If they are not, I would just give them tamoxifen first. Yep. And then after 1 year, I would check the hormones again. If they are still undetectable, then I will switch over to an AI and check the hormones every 3 months.
So do you
for
agree
6
that
months.
for our younger age group who is hormonal positive, okay, we also have to check their hormones during follow-ups if we do not do ovarian suppression?
It depends whether you want to induce menopause and whether you want to actually give an AI or not. Because for some patients, if for stage 1 patients, they may just do as well just having tamoxifen. Then you don't have to actually check the hormones. How about the
I
rest?
think it depends on the risk, right? it depends on the risk of the patient, as you mentioned
Yeah.
earlier. So if the patient is truly high risk, those who have high risk, then yes, I would want to give them ovarian suppression. So if let's say they are high risk and they're young, but they have not attained their menses yet clinically, then I would check their hormone level just to ensure that they are not menopausal yet, so I can now advise them to actually have the ovarian suppression on top of my hormonal treatment. But in terms of this patient that we are talking about, those patients who are iffy, those who are recurrent score 19, whereby you are thinking whether, you know, you want to give them a good hormone treatment which involves ovarian suppression, then yes. I mean, these are the patients that are not high risk, but they are low risk, but you want to give them the best treatment that you can give them.
If I may, I feel that when patients are on tamoxifen, doing their hormonal profile is tricky because you know you can't do it when they're on tamoxifen. It plays around with the FSH, LH levels. So do you take them off tamoxifen and then do the hormonal profile, or you still do the hormonal profile and interpret it that way anyway?
Yeah, I just interpret it that way, especially when they are really young, you know, like 30 something, 35 with high risk disease, stage 3 disease. We just have to.
So going back, Kylie, if I think about your case just now, this is a premenopausal lady.
Perimenopausal,
Hormonal,
45.
45. And I think the only high risk here would be the grade 3. The key 67 is 18%. That is another thing to discuss. The key 67.
Purposely one, yeah. Okay.
The key 67. So looking at it, maybe if I rethink about the case again, probably ovarian suppression is a viable option for this lady. We decrease the chemotherapy side effects, and also we get the outcome.
Yeah, it's hard to know. I think both ways are actually right. Okay, there is no right or wrong here. But if the IRS comes back as 12, then it's very clear that you
She's
chemo.
clinically high risk.
Yeah.
Clinically high risk, but genomic score is right. So maybe we just need to give them a bit more. I mean, I would do that. I'll discuss that with my patient.
Okay. So we'll go to the next case. So now this is a 55-year-old postmenopausal patient. Okay. Post surgery with a 34 millimeter invasive ductal carcinoma grade 2. 2 out of 19 nodes are positive and the margins are clear. So the ER is 3 plus 80%, the PR is 2 plus 30, and the HER2 is negative, and the KI7 is now 20%. So again, the same question, would you give chemo or would you consider genomics in this lady if let's say she can afford it? Anyone wants to weigh in? Yeah.
I think the size is a bit big.
We can always offer lah.
I'm feeling, given the 2-node positivity, the tumor is a little bit bigger. If you use your sort of 2+2 approach, which you mentioned before, right, in terms of the risk stratification, you could offer Memoprint, but also in a way, I feel I'm more inclined to go down the chemo route, giving that it's a little bit bigger and there's no positivity. But I wait to be proven wrong if the Memoprint comes back to show that it's actually a better behavior tumor.
Okay. So we'll move on. So we come back to this summary slide again. So for postmenopausal patients, we can use all of them. Okay. For N1 disease, we can use Oncotype DX, Memoprint, and EndoPredict. Okay. So of which the former two are the ones with prospective data. So with Oncotype DX, it is the RxPonder study. We should look at N1 patients, and for Memoprint, it's a MindDex study, which combine both N0 clinical high risk as well as N1 patients. Okay. So yeah, so this is actually a real patient actually. So we did memoprint on her, and this came back as a low risk luminal type A disease. Okay. So in terms of memoprint, right? So the study, right, actually looked at patients with discordant clinical and genomic risks. So these are patients who are clinical high risk and genomic low risk based on memoprint mainly. And then they randomized them to giving treatment based on the clinical risk, i.e. chemotherapy, versus giving endocrine therapy alone for those who are genomically low risk. So when you look at the results, which is a non-inferiority study, they basically show that giving endocrine therapy alone is non-inferior to endocrine therapy plus chemotherapy in terms of distant disease-free survival. So we can see here that when we give chemotherapy, it leads to a non-significant 1.5% benefit in 5-year distant mets free survival. So, this gives us confidence that we can forego chemotherapy in this patient, and this patient would mainly benefit from endocrine therapy. So, do you have any thoughts on this?
I think if I were to treat the patient with chemotherapy and then retrospectively somehow the memoprint came back, I would be quite upset because to me, I feel, because naturally to me, I feel uncomfortable giving extra treatment, although I know we all do it for the benefit of the patient or what we think is the benefit of the patient, but actually maybe it's not the best treatment. So yeah, that's my feeling on that. I would love to hear what the others think.
I think if we go back to why this oncotype DX, the background, right? The background of why all these genomic analysis studies was done it is because there was no there was just difference. There's just how to say, even the pathology specimen, right? There was a lot of variation. Even like, for example, grading, the grades, whatever that we have been using as the clinical factors, there are variation. Like Ki-67, it is not standard, right? So the reason for all this genomic analysis is actually to get a test where there will be little variation, so people can actually decide on the treatment with more clarity. Maybe Kylie can help me there. I'm a bit
No,
slow
that
today.
is exactly the case, right? So I think in the old days, we all think that clinical risk factors and us as oncos, right? We look at the T size and grade, and we can this one is chemo, But I think we need to move beyond that agak chemo kind of decision. But sometimes we just have to. But if we have these tools on board and the patients can afford it, then why not, lah? The other point to note is, if she has 2 nodes, does that actually worry you further? If we look at the subset of patients, right, with 2 nodes, there are not that many in the MINDEC trial. But if you look at the RX Sponder trial, whether it's 1 node, 2 node, 3 nodes, there is still no benefit with chemotherapy. So I think we can be fairly confident.
Yeah, I think in the end, all this test is actually to give the oncologist confidence to de-escalate treatment.
Yeah.
De-escalate treatment. Yep.
Yeah. Can I ask the panelists? All right. Okay. In government setting, most of the time we use predict score because most of the patients cannot afford this genomic testing. So how reliable this predict score? Is it wrong to use in this kind of situations, or can I get some advice from the experts?
It's not wrong to use. Okay. So predict sort of 2.0, it's just, it's based on big data, right? So it was definitely tell you that there is a benefit from whatever treatment you give. It's just to what extent only. Yep. So it helps with the discussion with patients lah. I mean, especially if these tests are not actually available. Yeah.
All right. Okay. So
Yeah,
it's
predict
reasonable.
and Yeah, predict is I think for the very high risk patient or very low risk patient, they can actually predict very well. But in the end, in the borderline patients, sometimes it's I'm not sure whether they are actually really validated in this group of patients. What do the other?
I think if I were to select, if let's say we need to give cost benefit analysis, right? The patients that I want to test this with are those who have lymph node positive, 1 to 3,
Right.
because we want to avoid chemotherapy in these patients.
Yeah.
And those patients who are those who are old, right? Then you don't have to do anything. You don't have to test. You just have to use the,
All right.
but those who are lymph node 1 to 3 and those who are like the one yang macam yang tadi lah, yang macam the first kan,
All
first one,
right.
Yes,
the one that
uncertain
Okay.
ones.
Right.
yeah,
Okay.
We
Easy,
cannot
then
right.
afford to
to them,
escalate treatment. Yeah.
like grade 3 tapi 1.5 cm, you know, like
Yeah. Right.
that kind I will use.
Yeah. Okay. Thank you.
I mean,
Can.
we also await, maybe there's an opportunity here, Ranga, for a study to validate, predict any
Oh,
test in the
yeah.
Malaysian population,
Right.
right?
Yeah.
Hey, who
Right.
knows?
Yeah. Yeah.
But hasn't
No,
it
we
been
have that
done already?
tool, right?
Yeah, we've done that already, right? For predict in
Not sure.
Malaysians.
Oh,
I thought
Sorry, I'm not
Namala has
aware of
done
it.
it. Okay. All right, Ken.
but now people are going towards the other tool, right? Where they combine genomic analysis plus the clinical factors. Can't remember the tool, clean
Can.
tool, something like that.
I think I will skip the last question, whether she should have a BIMA cyclip or not. Okay. Answers she should. I mean, I don't think she should lah. Okay. Okay, the last one. This one is a short one. So this is a 60-year-old postmenopausal. So 24 millimeter invasive ductal carcinoma, 0 out of 4 nodes. The grade 2. Okay, 6 out of 9. The ERPR is there. The HER2 is there. The KI is 20%. Cannot afford genomics. Give chemo, skip chemo, or other tools that can be used. Any thoughts?
We get Ranga to answer.
Okay, for me, 60 years old, postmenopausal, 2.4 centimeter tumor, 0 out of 4 nodes. I would go for hormonal treatment alone.
Okay.
Yeah.
Which is
I'll
very,
skip the
very
chemo.
reasonable lah, because she's also got grade 2 disease.
Yeah.
Okay. How about the rest?
I think I would tend to agree with Ranga. Even here, I wonder whether at online, adjuvant online or predict, I would impute it just to get a feel. But similarly, I have a feeling I would go more with endocrine therapy.
Can. Natasha, the same as well? You are muted. Sorry, we can't hear you.
I think I would agree with everybody. This patient should just receive hormonal therapy. Just one question to all of you. What's your cut-off point for your Ki-67?
20.
20.
That's my institutional cutoff actually. So I think it's based on your institution. So mine is
But
20.
that's why it's 20 here in this case.
Yeah, purposely.
Yeah, 20.
Okay.
Right.
Institution means what? The lab? Your lab?
Yeah, meaning when we discuss with our pathologists, that's what they are like consistently, or to they as a group of the pathologists lah.
Most labs don't validate lah, so that's the problem. So you can't say that 20 is the cutoff because we feel like it or because other people are doing it. But if it's properly validated, then you have your patients, you say 20, less than 20, you know that the risk is actually lower, as in you can see in your own patients. But most labs don't do that. We don't have enough patients. So anyway, for this patient, there is a tool that I want to introduce you all to. It's called the McGee score. Okay, so it's from Pittsburgh. So it's a really useful score because it is a score to predict oncotype DX score. Okay, using basic clinical risk factors lah. Okay, so here we basically use okay, if I do it here, wait now. Okay, so this is just a brief data. So it's based on a fairly large validation study of just over 1,500 patients. So when they define it as do not send, so if you go down this decision tree, do not send, because the score will likely be less than 26, okay, they are 95.1% accurate. Okay, so it's fairly chun, okay. And if we look at this lady's case, if we key in her scores here, you can see that all of her scores actually, okay, are less, are in between 18 to 25. And if we input the mitotic score, hers is actually 1. Then the chances of her having an oncotype DX score of 26 or more is about 4.9%. So this gives you a bit more confidence in your decision making.
We all still have our day jobs, thank God.
Yeah.
But can I just ask the mitotic score, how did you come up with that? Sorry.
In your grade, so
From the grading.
yeah. So
Okay.
in your HP report, they will give you the grading, 1 plus 2 plus 3, or 3 plus 3 plus 3, then give you, it's 9 out of 9 and it's a grade 3. Yep. So it's actually all in your HP report and you can actually input this. So it's actually quite useful. But it's only useful in postmenopausal patients because it only gives you a score of, they can only predict a score of less than 26.
Kylie, sorry, I have a question. How did you come up with ER 270? Is it 90 times 3?
It's a H score. Yes, correct.
H-score,
So if the H score is basically your 3 plus times 90, then 2 plus times 60 is 120.
Okay, right.
Yeah. Okay.
Thank you.
I think I better stop here. We can move on to the next case, yeah. Or unless anyone has any parting words of wisdom, yeah.
No.
Okay, thanks.
There are some questions though. I think there
Okay.
was a question about adjuvant online by Juni. Do you guys use the adjuvant online in your clinical practice? I think we did. Somebody mentioned predict, right? I
Yeah,
don't use
Adjuvant.
adjuvant online, but yeah, I just want your comments on this. I just feel like they're not specific and individually tailored.
But it's adjuvant offline, right? It's called
Yeah.
adjuvant. It's no more.
For more than 10 years already.
offline.
So if
No
I
more.
were to, I will
No
use
more.
predict, but are there any other online tools other than predict NHS UK, that one?
Cancer math is called. But the issue with predict is it predicts overall survival. It doesn't predict DFS. So if you look at OS, right, your numbers are 2-3%, and so it's it's hard to discuss with patients. Yeah.
Okay.
Can. Okay, so I will stop sharing. So perhaps we can, I think, go on to the next case, Nina's case, right?
Okay, can
Yeah.
do. Let me just share screen. Okay, can you guys see my screen okay? And hear me all right?
Yeah, can.
Yes.
Okay, thank you. So, disclaimer, I'm here really to share and learn. And this is a case of a colleague here in UM. So let's just take it through each scenario and share our thoughts on each part. So this is a story of a lady who's 29. She's got 2 children. And when she presented to UM, she was 22 weeks pregnant. Initially, she presented to Tumour Hospital. She lives close to there. and a biopsy showed atypical ductal hyperplasia. And so it was advised for her just to watch this. But then the mass kept on enlarging and she wasn't happy with the advice. So she went to a private center, Beacon, because the mass was enlarging. And they did another biopsy, and it turned out to be high-grade DCIS with TNBC with a high Ki67 of 50%, grade 3 invasive ductal carcinoma. This is a mammogram which showed a large heterogeneous mass, and the stage was CT3 and 2. So her axilla had lymph nodes, they were matted and palpable, but no SCF nodes. So just would like to hear from everyone in terms of staging. What are your thoughts about how you would pursue staging in this case?
Okay. Can I take this?
Sure, please.
So, I think for the risk to the baby from radiation, of course, is dependent on what is the gestational age of the pregnancy and what is the dose of radiation that is given, which is which differ according to what kind of staging investigation that you do. Chest X-ray, mammogram will be lower than CT scan, of course. And I agree that the use of radiation associated imaging, maybe with contrast, with CT, should not be withheld if it is clinically indicated in pregnant ladies, especially, for example, if you want to confirm whether there's any PE or if the patient has appendicitis or the patient has small bowel obstruction. So the benefit of the mother from this early and accurate diagnosis actually outweigh the fetal risk . So, but then if let's say if a patient is pregnant at 22 weeks and a mammogram has been done, a diagnosis has been made, the patient has triple negative breast cancer, the question is the CT staging necessary at this time point ? Does this aiming at this accurate cancer staging during pregnancy add value to me? Is it going to guide or change management of this patient? Because I'm very clear as to if I have a patient like this, I would start the patient on chemotherapy neoadjuvant, and I would give it up to the patients about 34 weeks . So that's why I wouldn't want to do staging in this patient, because regardless if the patient has stage 4 disease, chemotherapy for triple negative stage 4 is the treatment. If the patient doesn't have stage 4 disease, chemotherapy neoadjuvant in a patient with locally, very big tumor like this is the plan anyway. So a thorough discussion, of course, of the risk and benefits should be done with the patient, because although people say, nowadays they say, the radiation from CT scan or X-ray is actually quite low. There's not very much effect on fetal anomaly or growth restriction or pregnancy loss. But we know we are radiation oncologists as well, we know about the stochastic effect, right? That is not related to dose for the fetus. So it can cause, some sort of fetal carcinogenesis. Maybe in the future, the baby may get leukemia or something like that . So I'm still very hesitant on doing staging for patients who are cancer in pregnancy. So that's my opinion. I could be quite there.
No, that's fine. I think that the textbook answer, usually we would look for sort of chest X-ray, ultrasound of the abdomen, and so as you say, I think it's a good reminder in terms of your approach to any patients. Am I adding value with this test? I think that's just a generic thing for what we do day to day. So this patient had ultrasound abdomen, but then her chest X-ray showed some sort of reported by radiologists showing some multiple lung nodules, and
the chest X-ray was done for staging, right? Is it a staging chest X-ray? A patient going for surgery or something?
Staging chest X-ray, and then because the report and sort of further discussion, as you said, the radiologist didn't feel that it was going to add too much harm, so she had CT thorax low dose, which showed no lung nodules. So it's M0, but we can definitely see the very large tumor in the breast. and very positive lymph nodes in the axilla method. It's cut off here. The family history from the lady was that, so this 29-year-old has got a paternal aunt with breast cancer. So at this point in time, would you be thinking already about genetic screening?
Nina, sorry, I need to ask. The CT
Sure.
scan, the radiologist discussed with the oncologist before doing the low dose CT scan. How low is low?
Good question, Mas. I didn't look into that, but they convinced us that it was low dose, so we went with that.
So this is a CT thorax or CT thorax, abdomen and pelvis?
Thorax, just thorax, because of the chest X-ray.
Any other opinion from the other panelists?
Are we still talking about the staging scans, or we move on to?
I think we're still talking about the staging scan. I think Mas is am I right?
Happy.
Was unhappy is questioning whether we should have had the CT.
Yeah, I think that's how because sorry. Sorry. Okay, I'm just speechless. Okay,
no, Mas, it's okay. This is why we're having this kind of discussion, though.
Yeah.
It's a good point to bring across. Perhaps they would want to give a different combination chemotherapy and felt that it was necessary to stage the patient fully.
Fadhlina, I just want to ask you, do the chest X-ray really looks like they have nodules? When you look at it, mind the report.
Sure. I didn't think so. I wasn't convinced, but I'm not a radiologist.
Okay.
Retrospectively, I mean, it is all sort of retrospective, right?
Yeah.
Yeah, but then you see, if let's say you're trying to look for pulmonary embolism, you're trying to look for, some smallish thing, low dose CT will not give you that information, because low dose CT means that you are doing, what do you call that?
Screening.
The screening type low dose CT you're thinking about, right?
Correct. The sectioning is going to be wider.
Yeah.
Right.
That's why we need a radiologist in this meeting.
No, but then this can be told to the radiologist I mean, if let's say you want to understand if this patient has lung mets or not, because the chest X-ray is not clear, right? Then doing a low dose CT is not going to be the answer, because low dose CT means that you are going to do wider section. I don't know. I don't have that radiology thing, but yeah. If we want to look for PE, I like I say, I fully understand. We have to do CT but again, this is TNBC. That's so huge. Clinically, I'm quite sure that's so palpable. And then patient is only 20 weeks, right? Like 22 weeks.
Yeah.
Never mind. Sorry. So, but I would But that you're saying the radiologist had discussed with the oncologist and proceeded.
Yeah, okay. We are very big in our MDT. Yeah. So we're moving on to the next slide in terms of, would you at this point think, okay, there's a 29-year-old lady, huge TNBC, am I going to carry out a genetic screening at this point?
To
Maybe
me,
Kylie can take that.
To me, she's gonna need it anyway already, So and it will eventually affect her treatment as well. So to me, I would just do it already if she is agreeable, because I know that these things do take time to convince the patient.
Right. So this is the thing. I don't know what your patient population is like, but mine definitely always takes time to convince for this part. It's they're contending with this diagnosis, can't wrap their head around, and then you're asking, I don't know, in my practice, it's quite hard to get them to do it early.
What about Ranga?
Yeah, it's not a routine practice to do the genetic screenings. It will take some time. Sometimes we refer to HKL for genetic counseling, and we take it from there. So it will take some time. For most of the time, we just initiate the chemotherapy and then we refer them for genetic counseling later.
Okay, I wouldn't put my money in giving the genetic screening test at the moment. At the moment, like I said, I would just counsel the patient for neoadjuvant chemotherapy, which can be palliative chemotherapy if the patient has stage 4 disease. And otherwise, if I know that the patient has BRCA mutation right now, am I going to add carboplatin to her neoadjuvant treatment? That's the only thing that I can think of because yeah, I mean, we can always do it later. I think somebody who's pregnant and having this locally advanced disease, they have a lot to already digest. So
Yeah.
I would like introduce, but I would tell them that look, your cancer treatment takes a priority at the moment. We will revisit this once you are pretty settled.
Natasha, what do you think?
If the patient is agreeable, then is still strong to discuss about what if she's BRCA positive, because there's a lot of things to think about. Okay, looking at this case back, actually the CT thorax was very helpful if you think that she has metastatic, whether we are dealing with non-metastatic or we are dealing with metastatic. And if you are dealing with non-metastatic locally advanced, we are thinking of, whether BRCA can help in terms of deciding olaparib later, if she can afford, and whether if they are negative, then you would think about other things, right, later. So, and about risk reducing surgery later on, about the contralateral breast, and also she has completed family, and about oophorectomy and all. But I guess, as Mastura said, it's just too much an information for the patient to digest. But that's what the guideline would suggest, I think.
Thank you.
Actually, the whether it's stage 4 or stage 3, olaparib is going to be indicated. Like if you have BRCA positive early breast cancer, you have the Olympia study kan. If they have high risk disease, patient like stage 3, then it's indicated actually. Stage 4, then later on, if the patient has had the chemo, because I don't think we can give olaparib during pregnancy, right? I mean, I don't know.
I know it's about the risk reducing surgery. I'm just thinking whether if you want to go ahead with surgery, for example, kalau macam you buat LSCS, whether you want to do oophorectomy at that point, that kind of stuff, so that you can just manage it at one surgery rather than doing multiple surgeries.
And I think on that note, we will come to that very important point in terms of risk reduction. Okay, so we deviate right now, and we will go slightly into who would you offer genetic screening to. So as everyone knows, in NCCN, there's a huge long list of patients that you would offer genetic screening to. So anyone who's less than 50 or less with triple negative breast cancer or multiple primary and significant family history. So what the Malaysian CPG has done is they try to simplify, yet maintaining the detection criteria of this mutation at 10%. So this is the Malaysian Breast Cancer CPG's recommendation in terms of who would benefit in our population for cancer genetics. So in here, she is a patient with triple negative breast cancer, diagnosed 60 years, less than 60 years old, so she would benefit from it.
Yeah, I'm not sure about the triple negative breast cancer though. Okay, although the percentage of BRCA positive in triple negative breast cancer is almost 20% in that cohort, but and the BRCA positive patients in hormonal positive is way less. But we see a lot of hormonal positive breast cancer in our practice. Therefore, actually that BRCA positivity is way, we see much more in hormonal positive. So we should not forget the hormonal positive cohort.
Absolutely. So Yeah, I mean, in those patients, hormone receptor positive with first degree relative, as per number 6, they're captured there, and also they're captured in the breast cancer in patient diagnosed less than 45 years old. But
Yeah,
I'm
this
interested.
5% kan BRCA positive in all breast cancer patients. Actually, the number is very small.
So just touching based on the pedigree and what it means. So pro-ban is our patient there, and first degree relative is father, mother, siblings or children, and then second degree for this lady is the paternal aunt here. And this is the pedigree for our lady. So she was seen in the genetics, joint genetics clinic, breast surgeon, with the breast surgeon. So we can see that this is the lady in question, our patient, and her dad's sister had breast cancer at age 60, 61. So no other family history that's significant there. So what about online tools that are available for risk determination if patients feel that genetic screening is too expensive? So most of our patients get sent to Cancer Research Malaysia. The price is about 1,500 ringgit. So all in all, it's fairly affordable to patients. But what are available online tools to think about whether you want your patient is high risk or not? So there's CanRisk, and there's also Boardasia, and they're looking into sort of validating this in the Malaysian population, but the publication is not out yet. So the next question is, which genetic test panel are you going to choose? So we work quite closely with Cancer Research Malaysia, and it's the 19 gene panel that we send. And for this lady, the result came back as positive. She had BRCA1, and this is what it looks like in terms of the result. So I was having a chat with Sukyi in terms of how many genes would you test your patients for in it. So I just want to hear from the panel, what sort of panels have you chosen before, a smaller or larger panel in that sense?
I have an in-house, I have an in-house BRCA1 and BRCA testing, BRCA1 and 2 testing done. So that is just 1,000 ringgit. 1,000 ringgit. So if they do Invite is about 1,008, if I'm not mistaken. So I will usually choose based on what my patient can pay, because they use cash. They don't use insurance to pay. So it's not, I mean, we don't go that in depth into the how many genes lah.
I order like what you just ordered, which is the NCCN breast and gynae cancer guideline panel, the 19 genes. Yeah.
Because
have you found any genes that gives rise to anxiety and confusion and
okay, gives rise to anxiety and confusion. So I think if we counsel them well, it's okay lah. I mean, if they get a VUS, we know that most of the VUSs are going to be negative. In my entire career, I've only seen one BRCA VUS that became positive 4 years later. So I think it's fairly uncommon for VUS to be positive lah. And the report also gives you an indication whether this is going to be high risk or not. Also lah. So I'm fine with doing the 19 gene panel. I have got patients who are BRIC1. I've got patients who are BAT1, ATM. I've also got PAL-B2 as well from this panel. So if we just check for BRCA1 and 2, we do miss this other moderate penetrance genes lah.
Okay.
So these genes were pathogenic or they are VUS as well?
Pathogenic.
Pathogenic, yeah.
Pathogenic, yeah.
Can you do anything about it in terms of breast cancer?
There is no data. So the data for contralateral risk reducing surgery is mainly in the BRCA patients. And for PAL-B2, there's some early data, but it doesn't seem to be supported now. So it's mainly for high penetrance genes, yeah.
In terms of medication as well, because I think Natasha, the other day we discussed, right, the somatic BRCA and the germline BRCA for breast. So at the moment, as for drugs, only
BRCA 1 and 2.
germline BRCA in the early stage setting. In the metastatic setting, ER positive, HER2 negative, or triple negative breast cancer who has failed everything, and maybe if you don't have anything else to give, and if they have somatic BRCA or PARP-B2, maybe you can discuss with your patient about the usage of the PARP inhibitors.
So yeah, I know this is an advert for clinical trial recruitment. In we have Tumour study for TNBC in a metastatic setting, and we do panel testing for that for patients who can't afford panel testing otherwise. Okay, so by now she's 24 weeks pregnant, second trimester. So we're moving swiftly along. I'm not sure how much time we have. What do we think about management option at this moment in time? I think we've sort of touched upon that. I think Mastura was saying we're going to go for neoadjuvant chemotherapy at this moment. Any thoughts about going straight to surgery for her?
The disease was so big, right?
Yeah, very expensive. I don't think it's surgery is even on the cards, like it's not an option. So then we go to what regimen do we think would be the option for her here?
I will give the patient EC. The patient is 24 weeks, so she has 10 more weeks to go. So she has at least 2 or 3 cycles of chemo. So I'll give EC times 3 or EC times 2 followed by 1T depending on the response. So if she responds to the if she responds to the
I just wondered your thought about those dens in her. Would you think about 2 weekly EC?
Sure, because she has a large disease, right? Large volume disease. Yeah, sure. With GCSF cover.
Yep. So it's very, very reasonable.
She will have 4 cycles then, right?
And
she will have 4 cycles.
And also the chemo with the most safety data in pregnancy is anthracyclines, So
and it's also active in TNBC.
Yeah, it's also very active, right? So I'm very happy to give AC or EC upfront, and those stents would also be a good option for her.
Yeah, agree. So this is just the ESMO guideline in terms of early breast cancer and giving neoadjuvant chemotherapy to patients with TNBC or HER2 positive patient who's more than 2 centimeter. So there's no data. I think there was a study on velaparib in the neoadjuvant setting, not thinking that she's pregnant. If you're thinking in a female lady, whether you give neoadjuvant PARP inhibitors, so that study is negative. In a pregnant lady, pembrolizumab or IO is contraindicated, so you wouldn't be giving that here. So this is just the recommendation for neoadjuvant systemic therapy, and we've discussed the regimen. So this patient had FEC instead of EC. So I just wondered any thoughts about, I mean, it's not wrong to give FEC, but any thoughts about moving away from FEC into EC? What are the thoughts there?
I moved away from FEC for more than 10 years. So I think that is after the Italian study with, I can't remember whether it's 4,000 patients or 8,000 patients. That was when I was in UM, so must be 2012, 2013.
That's the GIM2 study. So we looked at whether they tried to answer 2 questions. The first question is whether those stents works, and secondly whether the 5FU adds anything or not. So the answer is those stents works, okay, and the 5FU didn't really add to any benefit in terms of long-term survival. So I think
included toxicity, right?
Yeah, and added side effects now. So I think my personal opinion, we should move away from FEC.
I'm with you 100%. But I think traditionally we do see a lot of FEC still being given. I don't know whether you agree with me, Ranga or Natasha, on this, but we do see a lot of that. And I wonder, actually, to me, I feel like change in practice is quite hard to do, because it feels like it's a knee-jerk reaction to give
Yeah,
FEC.
I totally agree with Nina. It's like a reflex regime, FEC, docetaxel, FEC. So I think we need to move away from the 5-FU based chemotherapy. I think so we give EC or AC regimes. I totally agree. Yeah.
I think we need to understand as well that is the guideline also says that we have to drop it. That's one. Second is we came from a background where we use a lot of chemos. Nowadays we have other drugs that also adds benefit to the patient's outcome. We have CDK4/6 inhibitors, we have PARP inhibitors, we have better radiotherapy techniques. So maybe we don't have to give patients so many drugs in order to get the outcome that we want. But I did hear that in the neoadjuvant setting, people want to give more drugs for that oomph in terms of the response rate in shrinking the tumor. So Ranga, what do you think? Is that also the what do you call that? The
practice, usual practice.
No, the feeling, is it because we want that response in patients huge tumor, for example?
I don't think
that's it,
so.
It's not that. It's a reflex. It's
a reflex,
embedded.
yeah.
It's embedded in the DNA.
If
if we have to be honest, right?
Yes, correct.
Okay. Anyway, in the interest of time, I'm going to move along. Addition of platinum in TNBC. So we were saying, so this patient then went and had 3 cycles of chemotherapy, and then had a healthy baby girl delivered at 33 weeks, spontaneous vaginal delivery, and then she had docetaxel. So would you be thinking about adding platinum instead of just docetaxel for her?
Can I say that this will be a good time to stage the patient?
Right.
And alamak, metastatic disease, right?
Yeah.
Change everything. So this is now the baby is out, we can stage the patient, properly.
But a question to Nina before that. Okay, before that, I ask your question first lah. I think the platinum data for adjuvant TNBC is not well established, so I would not add in this patient. It doesn't, again, like F added to EC just now. It doesn't add any extra benefit, but add toxicity to the patient. Why was the patient delivered at 33 weeks? The patient can go to term, right?
Spontaneous.
Spontaneous delivery. It wasn't
Spontaneous.
Baby wants to avoid chemo.
Yeah.
So, get me out.
Baby want to avoid the 5-FU.
maybe resulting
delivery is a mode of delivering the baby. Bukan maksudnya dia tiba-tiba spontaneously terberanak. That's not it.
I don't think they induce it, Mas. I'm sorry, Mas. This is a colleague's case, but I don't think they induce the delivery. I know that's another big important point to note, that we should let the pregnancy come to term, right, rather than induce early delivery, because that can have detrimental outcome on the baby.
Okay, but okay, maybe the others can talk lah. Maybe I can senyap now. I want to go and get coffee. Please carry on.
So I beg to differ in terms of platinum. So I think platinum is important. If you look at the studies for platinum, right? Okay, we know that it increases PAFCR. That's the first thing. Secondly, and most important that people always worry about is, does it actually change long-term outcomes or not? Does it actually improve survival or not? So we know that it actually improves DFS, okay, disease-free survival. So based on 2 studies, so including the larger brightness study, but the more recent study is the Indian study from, I think from Tata, that was presented in San Antonio just last year, which showed an overall survival benefit in patients who are less than 50 years old, i.e. her, you know. So in my opinion, and we want to try to achieve a good response for her, considering that she has locally advanced disease. So I would
But
give
this
it
is adjuvant lah, Kylie.
Huh?
This is delivery, right? Post delivery.
No, she's neoadjuvant.
Neoadjuvant,
Tumor is
neoadjuvant.
still there.
Neoadjuvant.
The tumor is still there. We delivered the
Post
baby.
Delivered the
only.
baby. The tumor is still
The
there.
tumor haven't been
We delivered
delivered yet.
I mean, I wonder, you know, what you guys do. You guys usually do give platinum in the neoadjuvant setting? Because I do, but I wonder.
Okay. Yeah, I believe in the data in the neoadjuvant setting for TNBC. Tapi adjuvant, I didn't hear, but there is overall survival advantage. Is it, Kylie?
Based on the Tata study that was presented, it's a fairly large study that was presented at San Antonio. So we showed that there is an overall survival benefit, but mainly in women who are less than 50, the younger women. Yeah.
Okay.
So yeah.
Sorry, can I ask, like, okay, let's say the platinum triple negative, do you guys just give for those who are BRCA mutated, or those who are BRCA wild type also, do you guys subject them? Then how do you sequence? Do you like give platinum first and followed by anthracycline, or anthracycline followed by platinum? How's the sequence?
If you're not talking about the patient who is pregnant, I mean,
It's not the pregnant one.
Neoadjuvant memang we give neoadjuvant as per keynote 522 lah. So the patient will have docetaxel and carboplatin 4 cycles, right? And then EC 4 cycles with the pembro. So if the patient doesn't have that keynote 522 regimen for me, that I will still use the same regimen but without the pembro in the neoadjuvant setting. Because the response rate is been good in terms of giving me PCR rates for my patient lah. Tapi kalau patient tu is like not heavy node positive lah. The patient is triple negative breast cancer, cannot afford pembro. Maybe like tumor is 5 cm, no nodes, right? I may not go as radical as that lah. So I can just give EC and T 6 cycles neoadjuvant.
All right, thank you.
We have 15 minutes left. You guys, the discussion.
I feel that I'm going to close now because I think we do need to discuss Ranga's case. Okay, so the only thing to say is I think the sorry that we can't do this, but in terms of adjuvant treatment, right? So we have a BRCA patient. Would you give, you know, so you have the PARP inhibitor from the Olympia study versus Keynote 522 pembrolizumab versus CREATE-X study, right? So which one would you go for in the adjuvant treatment? Clearly, they all have different outcomes. Just saying, sort of Keynote 522 with pembro showed event-free survival benefit of, I think, about 8%. In the Olympia study, again, 8% DFS at 3 years. No long-term result yet. In the CREATE-X study, there is an overall survival benefit in the TNBC subpopulation of, again, I think about 8% there. So I just wonder, I mean, clearly it depends. If the patient has had neoadjuvant IO, then you would give them IO for a year afterwards. And if the patient has, you know, BRCA, then maybe you'd give PARP inhibitor instead. But I wonder how you guys make sense of this data. Kylie?
Okay, so this has been extensively discussed in this field. Okay, so maybe olaparib, the latest update showed overall survival benefit already. So we have OS for olaparib, we have OS for capecitabine, we don't have OS for pembro. Okay. We know that all of them at least has some kind of DFS or EFS benefit, as in it reduces the risk of relapse. If the pockets are deep, okay, they are fully insured, right? So I would give this patient pembro and olaparib. Okay. There's no randomized study that is going to answer this. Okay, there are some studies in the metastatic setting that suggest that it's safe to give together, whether it's pembro and olaparib or pembro and capecitabine. So safety is there. Now, if the patient achieves a PEF-CR, there probably is very little benefit to give anything extra. And we know that the patient wouldn't qualify for Olympia as well. But should you continue the pembro beyond the surgery or not? If they achieve PEF-CR, it depends also on how deep the pockets are, because the EFS benefit is 1% between for the PEF-CR patients, whether you have pembro or not. So if the patient cannot afford it, then I wouldn't push them. If they don't achieve PEF-CR, the absolute benefit for pembro over no pembro in terms of EFS is about 10%, which is quite large, you know. So those patients really need the pembro. Capecitabine here, if she's BRCA, I would opt for olaparib over capecitabine. Okay. Cape-wise, there's data to suggest that it's mainly the main benefit is in non-basal tumors. Yeah, so she is probably a basal TNBC. Yeah, that's my take.
Okay, thank you. I think we should wrap up here and let Ranga carry on. Thanks, everyone.
Thank you.
Right. Okay. So I think I start sharing slides. Okay. So I believe everybody able to see my slides.
Yes.
All right. Okay. So I have this 52 years old lady, para true history of total abdominal hysterectomy done in 2015, and she presented with raised breast lump for the past 3 months, and clinically right breast mass was 2 centimeters in size, and mobile, no skin changes, no axillary node. All right. Sorry. Okay, so her investigation ultrasound, there's some dilated ducts in the right breast, a 6 o'clock position. There's a maximum dilation was 14.5 mm, the no auxiliary nodes. So she did FNA. So this shows atypical ductal cell seen suspicious of malignancy. Chest X-ray was clear lung field. So she underwent mastectomy and axillary clearance in June 2023. Her post-op HPE actually shows DCIS component around 80%. Unfortunately, she has 7 mm of focal invasions, right? So she's invasive carcinoma, 7 mm tumor. LBI is negative, grade 2, and margins are clear, and lymph node 0 out of 20, KI 67 is 90%, ER/PR negative, HER2 is 3+. Right, so we have this postmenopausal lady, T1B, 7 mm tumor, grade 2, LBI negative, 67, 90%, ER negative, and HER2 positive tumor. Right, so what's your options of treatment? Right, would you guys offer surveillance alone or chemotherapy? If yes, then what is the choice of chemo? Herceptin, 6 months or 9 weeks versus 1 year, duration of systemic treatment. Maybe we start with Dr. Kiley first.
Oh, okay. So also it depends how deep her pockets are as well.
Right.
So
okay.
So we know these patients, especially the ER/PR next and the HER2 positive disease, right? Even T1Bs as well, their risk of relapse is higher compared to those who are who are HER2 negative. So we often quote risk of relapse in between 10 to 15%, around there, or even up to 20%. So generally, I would discuss treatment with them. I would give them a de-escalated chemotherapy with weekly paclitaxel and trastuzumab for a year.
Right. Dr. Mastura, any suggestion? Any point of view? You're breaking, sorry.
I think grade 2 to grade 3. But anyway, she's ER/PR negative and HER2
Yes.
positive. 7 millimeter disease, right? So I
Yeah.
would offer her the APT regimen with weekly paclitaxel and weekly Herceptin alone, followed by 3 weeks, is for 12 weeks, and then followed by 3 weekly Herceptin up to 1 year.
Right. So would you consider 9 weeks or 6 months of Herceptin in this situation?
If the patient doesn't have any money,
Right.
then I may if the patient has no money lah. But in the ideal situation, the APT regimen would be what I would choose for the patient. I think the data for the APT regimen is so far for the this kind of cases lah, stage 1 between 5 mm to 3 cm disease. I think it has the best kind of outcome.
Right. Dr. Natasha, can I ask you, what do you think about TC regime? Do you think I'm overkilling her if I give TC regime? Docetaxel and cyclophosphamide. Because sometimes I think we have problems in our daycare because we couldn't cope up. A lot of patients we need, because weekly paclitaxel, the patient needs to come every week. So do you think TC times 4 together with the Herceptin is a reasonable option? Maybe Dr. Natasha or Dr. Nina?
All right. Okay. So basically, Ranga, in the end, we are going to choose the data that has that is more in terms of accuracy. Probably the data of APT is better.
Right.
But then, yes, for our patients to come weekly for PACLI, and then for 1 year of trastuzumab is quite difficult for them. So it's difficult to convince them to come for weekly. For them, weekly times how many weeks again?
12. Yeah.
So
12.
for them, it's like 12 cycles. Sometimes
Yes, 3 months treatment.
yeah, 3 months. For them, it's 12 cycles, like coming every week. So for these patients, we want to de-escalate as much as we can. Probably TC and probably also 6 months of Herceptin rather than in 1 year for a year. So,
Ranga,
Yep. Fadhlina.
most of my patients have got no money, right? They don't have
Right.
deep pockets. So this is
Yeah.
the reality of where I practice.
Yes.
And I really like the elegant data by Persephone, which showed sort of I think about 4,000 patients, 2,000 in each arm, 6 months versus 1 year of trastuzumab. And so I would be thinking more along that line, because in reality, if I can get as many cycles of trastuzumab, then that's what I'm faced with on a daily basis. I mean, the patients in Persephone also mostly are hormone receptor positive, sort of more node negative, if I'm not mistaken, disease. So I would be thinking ECTH for this lady with 6 months of trastuzumab.
Right. Okay. We know this ER negative, HER2 positive is slightly higher risk compared to ER positive. And if these patients turn out to be 7 mm tumor, but she has a ER positive, HER2 positive disease, how do you guys approach this patient?
Okay.
Or is it
So I would treat her the same actually. If the patient is really okay, the other option, if let's say the patient wants to avoid chemotherapy altogether, there are two other options. One is endocrine therapy and trastuzumab alone. So there's a Japanese study, looking at that. And thirdly, there is the ATTEMPT trial as well, which look at TDM1 for 1 year. What was like, it's targeted chemo for 1 year. It will burn many holes in the pocket. But it is, I mean the data is also there. The 5-year data is out and it looks pretty much as good as APT. Except that there are more patients who discontinue treatment because of the long-term tox from TDM1.
Sorry, Kelly, this TDM1 is for this ER positive, HER2 positive disease?
For HER2 positive, stage 1.
Right, okay, right.
Stage 1 HER2 positive, It's from the same people who designed APT. It's from Sarah Tillani's group.
Right, okay. So I just want to share a few slides here that I took from some ESMO preceptorship. So initially, early HER2 positive breast cancer, we just categorize them low risk, sufficient risk. Low risk, we go for no chemo, no trastuzumab, and sufficient risk, we go for 1 year adjuvant. I think we are moving towards need to really stratify these patients, whether this patient falls in the category of very low risk, regular risk, and high risk, right? So what this MC Anderson hereditary series shows us tumors less than 1 centimeter. If HER2 positive disease, the recurrence-free survival is much lower compared to those who are HER2 negative. So, and also the retrospective series shows that if, even though the tumor is less than 1 centimeter, the 5-year recurrence-free survival is much lower those who are more than 0.5 centimeter. So I believe this kind of patient should warrant a chemotherapy because the recurrence rate is high. Right. So, of course, there are a few studies. This is a single-arm trial, phase 2 trials. It shows TC times 4 plus 1 year trastuzumab. And the DFS benefit is for 2 years and overall survival 99.5 is maybe adequate treatment for those who are not negative tumors, right? And another trial is about, of course, the standard one, the paclitaxel weekly with the 1 year trastuzumab. It shows a great DFS benefits around 98.7%. It's very commonly used regimen in the clinical setting for low risk HER2 positive cancer. Right. So this is kind of interesting. There's a fair trial where we can de-escalate the trastuzumab. So you can see here 1 year versus 6 months. In this very low risk patient, those who are less than 2 centimeter, it's around 1,000 over patients. The benefit is actually no difference, right? In short HER trial also, there's not much difference in 1 year versus 9 weeks. But bear in mind, those who are high risk patient, 1 year does, I mean, it's important to give for 1 year because the metastatic-free survival is significant, it's 3.6%. Right. So, so this is something interesting that I took from the ESMO as well. So, de-escalating adjuvant trastuzumab, it's actually reducing the cardiotoxicity and financial costs and demands for health resources. So, I take it from short head trial where the low risk patients. When, of course, as I mentioned earlier, 91 to 92, that much difference. When you look at the cardiac events, the grade 2 cardiac events is 14.6% for those who had adjuvant Herceptin for 1 year, and those were 5.1% for those who had 9 weeks. So it's kind of unjustifiable in low risk patients. But of course, those who are high risk patients, the cardiac risk is grade 2 and more is of course more prominent for 1 year compared to 9 weeks, but it's justifiable because the disease-free survival is 80% versus T, so the difference is 20%. So sometimes I think we maybe can consider in low-risk patients, we can give 9 weeks or 6 months of adjuvant Herceptin. Right, so this is something that's it's just a summary. I think weekly paclitaxel is what we normally practice, and those who are 6 months, trastuzumab 9 weeks is a reasonable options. Of course, it's cost saving and reduce the hospital visit, and then median free survival and DFS benefits, and I think it's good, and the cardiotoxicity is much lower. Those who had a shorter duration of trastuzumab. Right, so yeah, this is the recommendations for previous ESMO. So those who have 1B disease without poor risk factor, maybe no need to indication for the adjuvant chemo and trastuzumab, but with poor risk factor 1B disease, we have subject them on chemo with de-escalation. So they're talking about de-escalation of chemotherapy and also shortening the trastuzumab duration. Right, so this is the algorithm. We all know that MDT is very, very important in breast cancer management. So those who have tumor more than 2 centimeters should go for neoadjuvant systemic treatment, and together with pertuzumab trastuzumab, you know, the PCR rate is 60%. Right, and then if low risk patients, if we happen to see T1B diseases, so sometimes less than 2 centimeters, if the pocket is not deep, so probably we can de-escalate trastuzumab. Is something that we need to think about in the future. Right, thank you from me. Any comment, Dr. Mastura?
So in the Ranga, did you give TC for the patient, or is it?
This KV, I give TC. Yeah, I think then my staff nurse will look after me, or come after me if I give weekly. So in the daycare, so I give TC regime for this lady.
And 6 months Herceptin.
6 months Herceptin. Yeah, 6 months Herceptin.
Can I make a comment? So for all the de-escalating trials in terms of the duration of trastuzumab, most of them actually had anthracycline-based chemotherapy. Persephone, Farah, the largest ones, right? I think about 90% of them had anthracycline chemotherapy. So, and yes, there is a non-inferiority was met for Persephone, but was not met for the other 3 or 4. Okay.
Right.
Persephone was, okay, it depends on what inferiority margin was set for the trial as well. So if the trial sets a very conservative margin, I think like for Persephone it's 1.3 hazard ratio. So they accept that the sort of the 6-month arm can be 30% worse and it's fine. We can consider it as non-inferior.
Right.
If you look at the subgroups for Persephone, in the subgroup where they receive concurrent chemo and trastuzumab, right? You see it is not non-inferior already. The hazard ratio actually went beyond 1.3 as in the upper limit of the CI. So it went up to 1.5. So we just have to take that into consideration. But in a cost-conscious situation, of course, any amount of trastuzumab is better than none, whether it's 9 weeks or what. Yeah. But in people with deep pockets, we have to, I guess, take into consideration all of that.
Right. Thank you.
Again, Kylie,
I think that
I'm just wondering whether when we de-escalate, should we de-escalate both? And whether we can de-escalate the chemo but maintaining the trastuzumab, or de-escalating the trastuzumab but, keep the chemo with anthracyclines. So I think that is the 2 important questions that whether to choose whether to de-escalate the trastuzumab arm, or is it to de-escalate the chemotherapy arm, or can we just de-escalate one without maintaining the other arm?
Okay, for me, I risk classify my HER2 positive disease lah. So I don't add hormone receptor status to the HER2 armamentarium. So if someone has HER2 positive disease, regardless of their ER/PR negative or positive, they are considered low risk if they are small, like in Ranga's case. So stage 1A with like grade 1, and I don't give them anything unless they are very young and they are so keen, then that's different. If they are stage 1B to 1C with some good clinical features like low risk, right, then I go by evidence. So like I mentioned, the APT regimen, or the same like the Saratolani, the ATTEMP, the APT, so they memang look at low risk HER2 positive lah. So in the APT regime, they only include patients who are less than 3 centimeter, if I'm not mistaken, or less than 2 centimeter.
3.
No, 3, less than 3 centimeter and node negative, right?
Yeah.
Yeah, so node negative less than 3 centimeters. So in this patient group, they give the weekly taxane because they want to see whether taxane alone without the anthracycline is good enough. And then they add the Herceptin. So they give it weekly for 12 cycles. So that's 3 months. And then they follow by Herceptin only up to 1 year. And that came out with that results. I think that result is already, they have already, it's quite, I wouldn't say mature, but it's already quite long. So the follow-up, quite long already. The ATTEMP regimen, ATEMT, that one is the TDM1 versus the TDM1. That one is even, that's for stage 1. If the patient has lymph node positive, it's micro metastasis. So it's like T1N1 but micro. So this ATTEMP study, they give TDM1, which is, as you all know, TDM1, and they gave it for 1 year. I think the only setback to that, Kylie, is the thrombocytopenia, and it's kind of new. It's only like 3 years. 3 years data has been presented, something like that.
The 5-year data is out, so it continues to show good outcomes. But the main issue is okay, to have TDM1 for 1 whole year is not easy lah. Okay, it is much easier to have weekly Paclitaxel for 12 weeks, and then for 9 months you holiday with the trastuzumab. Very, very easy, right? But for TDM1 for 1 whole year, TDM for 1 whole year, you get thrombocytopenia. People feel like it's a gentle chemo for 1 whole year. But there are some benefits. You get to keep your hair. There's less neuropathy. Yeah, so we have to discuss with patients.
So in addition to that, those who are not in this low risk category, those who are 2 cm and above, okay, and we give them neoadjuvant, right? We want to give them neoadjuvant.
Yep.
So this 2 cm category, if they go to MDT, please give them neoadjuvant.
Yep.
Then after the neoadjuvant, whatever the result that you get, you can de-escalate if they get PCR. Those who see you already surgery done, right? Then if they are considered as high risk, then I would not treat them with APT regime or attempt. I would give them DCPH or whatever lah, depending on their positivity or not. So that's why Natasha, for me it's quite clear lah. I will escalate if they're high risk. I would de-escalate if they're low risk. So escalate high risk means whole jing bang. De-escalate means I would just give one drug that I mentioned just now. But that's my
So to answer Natasha's question, whether you de-escalate the chemo or you de-escalate the trastuzumab, if I was the one having chemo, I would rather de-escalate the chemo. Because I think to have anthracycline taxane and 6 months of trastuzumab versus weekly Pacli and 12 months of trastuzumab, yeah, to me it's quite clear. I mean, the latter would be less toxic, and yeah.
I mean, that's one way of looking at toxicity, though, Kylie. My patients have financial toxicity, so that's the
yes,
other issue that we really
Money
need
is different.
to talk about. And also just coming back to Persephone, when we talk about sort of how do you check the confidence interval, right? And then the 30%, how do they set that? So for a non-inferiority trial, it's a discussion between an expert group oncologist and the patient representation in terms of is this 30% relative risk reduction acceptable or not acceptable. But when you look at the DFS, it's 89.4% versus 89.8%, 6 months versus 12 months. That's 0.4% difference. But I totally get your point. We need to look at the specific stage that the patient is in and the risk factor. So it's not a blanket uptick of Persephone.
Yeah, I think I agree with both, but just to add, I think something very, 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 very important that Kylie highlighted was that the fact that when we give the patient concurrent anti-HER2 with the adjuvant chemo, that's when you see the largest benefit. So if, let's say, for example, the APT regimen where you give the weekly paclitaxel together with the Herceptin weekly, and then you follow by the Herceptin, if you want to compare that with another study which gives the chemo first, then sequential Herceptin for 6 months after that, I don't know whether you could
there are studies to look that look at concurrent versus sequential, or if you look at the long-term data, so there is OS only in the concurrent studies. The sequential ones, there are DFS benefits, but it didn't reach the OS. So that's why the standard of care is concurrent chemo and trastuzumab.
Another additional point, the other additional point that Khadi brought up about the Japanese study with hormone and anti-HER2 for those with low risk, is it? ER positive, HER2 positive.
Yeah.
Another study that also look at this small subset of the population is the SAFE-HER study, where they actually took patients who are frail and unable to have chemo, or they have lower risk, T1, T2 and not disease and cannot have chemo, right? And they give them upfront just hormonal therapy without chemo plus a study. So I think for patients with ER positive, HER2 positive, treat them like HER2 positive. Treat them as running out of time. So much discussion, so much challenges.
I think there's one question, Mas, from the Q&A.
Yeah, I think the question is for me. what are the poor risk factors in a low risk patients. There is the one, right, Dr. Nina? Yeah.
Yeah.
So
in terms
grade
of,
2, yeah.
yeah.
It's a grade 2, grade 3 diseases, and those who are less than 35 years old and ER negative patients. Yeah. Correct me if I'm wrong. Agree? Yep. Yeah.
Those are the clinical risk factors. You
Yes.
remember the first discussion that we had with Dr. Kiley's fire chat, where the clinical risk factors that we look at when we're deciding chemotherapy for patients, other than nodal positivity, would be the grade, the Ki-67, age, very young age. Okay,
All right.
Tasha,
Thank you.
your case, right?
I think we are 6:45 already. Time to
Tasha,
Prepare my
your
case
turn.
because Kylie said not to prepare. There's too many cases to discuss already.
Yeah, but then the cases are all good. This is our day-to-day challenge, right? Okay, blame Nina for that too long. Oh, I'm still upset about the CT scan. Okay.
Don't bug you.
Am I lagging or I cannot hear Natasha?
No, I didn't say anything.
Oh,
okay.
okay.
I suppose we
Lagging.
can
I'm lagging too.
close lah. Yeah.
So Natasha doesn't have any case lah.
No, when we discuss about the cases,
Okay.
Kylie said there's too many
Okay.
cases already, so
My
I
bad,
should
my
not
bad.
prepare.
Sorry.
Yeah.
Too many. Okay. So we can close. So okay, if I can round up, I think there are some questions, but I guess you guys can also answer that question if you want. Okay, in the question and answer session there. I think the ones that are there any are you guys seeing the questions? Are there anywhere there that you want to add anything?
I think no more already. I think Ranga answered that question already.
No, in case you guys want to add anything there. Okay, so okay. I think what is very, very important that I'm happy that Nina highlighted is the fluorouracil to the FEC. Please drop. Drop the F. Drop the F. Okay, and thanks, Kylie. I think you have taught us a lot today with all the fire chat and your commentary as well as cases. And Nina, I think the cancer and chemotherapy in pregnancy is going to be, we're going to see more of that because more and more patients are getting married late and being pregnant at the right age where they get increased risk for especially breast cancer. And thanks, Ranga, for your case, because we do see this and we always see these patients with early stage and we thinking like, hey, do we have to treat this patient, especially if they're old,
Yeah.
But
Thank
then,
you.
but when they come with your brain mets and liver mets, and then you like, sharp, you.
Yeah, that's the dilemma.
Yeah, because you are going to see the patient and say, okay. Thank you. Any other thing? Okay, so thank you to the audience, to those who also post questions. We have our next session in September, but we will come to you to let you all know about the tumor site in September and who are going to be the panelists next time. So please give feedback to this webinar. I think we have improved somewhat from the first one. At least today nobody's texting me, cannot come into the chat, you cannot log in. Okay, so please scan the code there for your points, as well as please give feedback. You can reach me personally also if you want to give me feedback about the happy to you guys. Thank you.
But
Okay.
thank you everyone so much for the opportunity to learn from everyone. Thank you.
Yeah.
Likewise.
Thank you so much for the
Bye.
opportunity. Thank you. Thank you.
Yeah.
Bye.
Okay.
Bye-bye.
Good night. Bye-bye.